So I'm David Malkin. I'm a pediatric oncologist at Sick Children's Hospital in Toronto, and this project funded by Genome Canada, one of the major partners is Genome BC, as well as many others, including our end users' brainchild, which you'll hear Elizabeth Peters tell you a little bit about. The most common cause of death in children, aside from accidents, is cancer. And the most common form of childhood cancer are actually brain tumors. And the biggest challenge for us in the pediatric oncology world is that while we treat and cure about 80% of children with cancer, that other 20% are particularly challenging. What we don't know often is, looking under a microscope, a brain tumor, a particular type of brain tumor, whether they do well or whether they don't do well, looks exactly the same to the pathologist. And so the basic premise behind our work is to use genomics and genomics research to try to better identify those children who have a tumor which has a particularly bad prognosis from those that have a particularly good prognosis. We've already, in our early stages, been able to show that using this ability to what we call stratify or separate out the groups, we have shown that one set of genes predicts that a child has about an 80 to 85% likelihood of cure, whereas another set of genes has a cure rate that approaches zero. It's virtually none of those children survive. All of those children get the same treatment. So the children who have a great prognosis are getting radiation to their brain, high-dose chemotherapy, very significant surgery procedures, and that can cause very significant late effects so that we have survivors with very significant disabilities costing up to $1 million a year to the economy, as well as all the psychosocial aspects for themselves. Whereas at the other extreme, we have children with no likelihood of cure, and so a big question that goes to the families that we're trying to understand in this project is, how do they decide between treating with all the concomitant side effects versus perhaps cutting back on therapy and allowing whatever life is left to be as good as it is. So by separating out these groups now, which are all called brain tumor or medulloblastoma, this particular type, we're now able to allow families to have a better idea of how to and treat in the families. We know it can be done by an experiment in nature, if you will. One of my patients, with a picture of here, was a young girl, or is a young girl, who was 2 years old when she was treated. And her parents elected not to give radiation. And she's now in college and doing extremely well, and is actually going to be at one of the public launches for Genome BC, Genome Canada in January. And what she demonstrates is she probably had that very good prognosis tumor, but we had no way of knowing it at the time, and so it was just almost luck that she didn't end up with the long-term effects. So that allows us to now talk about the economy of this whole project, and we're hoping that in the end we'd be able to predict about a savings of $25 to $50 million a year in the cost to treating children with late effects of these treatments by eliminating that group altogether, because they would all be treated with minimal drug therapy. So Elizabeth has been on the other side of this coin.
Well, my daughter has a brain tumor, and so any of the research that can be done that offers hope and offers parents a chance to have the opportunity to have more control over a situation where we have very little control is wonderful. And the idea that we can have a choice of what treatments to give our children is wonderful. Well, absolutely. If we have more information, we can make a better choice for our child rather than just hoping we're making the right choice.
Just kind of looks a little